Today on the Diabetes Podcast.
You are not diabetic. There's no other condition. You don't say, I am carcinogenic. I am cancer. If these beta cells aren't dead, as thought before,
If the scale is the only tool that I have to measure success, how do I know that I'm doing it right? How do I know that I just didn't lose 10 pounds of water? Hello and welcome to the Diabetes Podcast. I'm Richie.
And I'm Amber.
And Amber, today, just doing a one-off. This is not a series. This is going to roll into that. Today we're talking about, I think, something that ends up being a stumbling block for a lot of people. Talking about mindset, but specifically mindset around remission. Why is it that you don't see a prevalence of what we call the remission mindset in the majority of the people that we interact with?
Yeah.
And what are some of the, I don't know if self-sabotage is the right word, but what are some of the, let's just say, some of the framing around this disease that could be improved and would result in actually seeing those numbers start moving in the right direction?
Yeah, I've done this a long time. And I think that is a question that a lot of people who work in diabetes, a lot of people who have diabetes, a lot of people who are told they have prediabetes, it's a question that's circling around and in different forms depending on if you're the healthcare provider or if you're the patient or if you're the person who was just told this. And I think that a lot of what I hear is, I wish I had known that. I wish someone had told me this. And I think especially now in the information age, sometimes it's assumed that there's bare minimum things that people know, and there's a limited amount of time in healthcare. So to bring it back to your question, because I think I immediately wait, is the mindset is usually denial in the beginning. And I think there's many reasons for that. Number one is the social stigma, I think, is some of the biggest. It's not something that you want to call your friend or tell your family and say, oh no, I just got diagnosed with diabetes. Because something we also talk to is that you are not diabetic. There's no other condition. You don't say, I am carcinogenic. I am cancer. I don't know of many other disease states where
It's
the
an identity
ownership
statement.
is an
Yeah.
identity. Like the statement of the disease itself is an identity statement. And I
So
think,
if we
yeah.
can, I think it's probably worthwhile to take it back a step further.
Mm-hmm.
In your plus 23 years of experience, how does the normal rollout of you are diabetic work? Because that's not something anybody seeks out and is going to take on themselves. How does that happen? How does again, typically, it can vary, but typically, how does one become diabetic or
Well, how one
become
becomes
aware of
diabetic is
their
completely
state
different of how they become aware of it.
diabetes? Yeah.
Yes. So it depends for men versus women, because women are more likely to have preventative healthcare checkups over men, and men tend to not go until they haven't felt bad for some time. And so it's first getting to the doctor, doing labs that the doctor may recommend based on symptoms. So oftentimes the first symptoms are just feeling tired. If it's more severe in progression, the symptoms might be extreme thirst, extreme tiredness, extreme urination. And usually if somebody comes in with those symptoms, it really requires multi-med therapy on top of nutrition, lifestyle interventions right from the get-go. And that's where we talk about the meds being the scaffolding and then the diet and exercise on top. And in a perfect world, someone would get told that and then go immediately to see a certified diabetes care and education specialist, a registered and licensed dietitian, maybe someone who specializes in diabetes and exercise physiology. This multidisciplinary approach to care. They'd see a pharmacist to see if the new meds that they're starting are going to interact with other meds that they're on. But that rarely occurs. There are so few diabetes centers of excellence in the nation. And then the ones that are there might have, you're required to have so many disciplinary professionals, but sometimes some have more than others and some have less. Like I think the minimum is 3, like a nurse, a pharmacist, a dietitian, and then they really recommend you have 7 or 8 different disciplines with that. And then you've got a physician head, and it varies wildly depending on who the physician head is and how involved they are as well.
Given the scope of the disease, given
Right.
the prevalence of the disease,
Yeah.
why do you think that there are so few kind of resources surrounding this?
It's an excellent question. And the curiosity point for me is less that the resources exist and more of maybe those resources aren't properly utilized and being aware of. When I worked for a diabetes center, I had about a 50% show rate for appointments. And in general, these type programs are not financially beneficial for institutions. They're usually in big hospital conglomerates, and they receive funding from bigger departments like cardiology and maybe renal disease and kidney stuff, and so, or GI. And so those funnel money to just have as a resource for patients. Like our diabetes center, the one that I worked at, was one of the few that was profitable with a 50% show rate. And we also would truck it over to the main hospital to see inpatient cases of newly diagnosed diabetes, type 1, type 2, type 3C, all of these things, and like pancreatectomies and steroids and all sorts of different things. So there are ways to make it profitable, ways to increase awareness, but I don't think that's historically been fully utilized. So you have someone who gets diagnosed, and then where do they go? Where do they turn to? And you and I both know the answer is the internet. We all know the internet is the answer. And there's so much information there. Some of it is fantastic information. Some of it is the opposite of fantastic information. And then the other part of that is, how do you put it all together? How do you get it into a way that makes sense? How do you get it into an actionable plan? How do you make changes within that?
Okay. So why do you think that remission from prediabetes and type 2 diabetes is not more part of that initial conversation?
Part of me has no idea. And the other part of me understands that some initial research on this was about this pancreatic beta cell destruction. That was what was thought to be true at one point, that by the time someone's diagnosed with diabetes, this has been going on in the background for 6 to 10 years prior. And at diagnosis, they have 50% beta cell function. So then it's just this continued progression into requiring insulin and continued decline. It's always been considered a degenerative type disease. And with, I don't want to say newer because it's not all that new, but with research that's come to light since then, it really talks about what we covered in the episode on pancreatic beta cell function, that these beta cells aren't dead as thought before. They're on break. and whether or not they come back off a break.
Hibernation, I think, is probably
Hibernation is a great way to think of it. Like they're dissociated, if you will. Like they are not doing the job of a pancreatic beta cell. And so to get them back online takes doing something different. It takes major behavior changes, major lifestyle changes. And I say major, knowing that it really isn't, especially in the beginning, that it's just changing certain things. And we don't have to get into the execution of that. We talked about it a lot, but it's just getting those back online. And it is possible, because I think for the longest time, people thought it wasn't possible. For the longest time, people thought it wasn't possible to run a mile under 4 minutes. And now everyone, I say everyone, I can't do it.
There's doing it. Yeah.
Yes, exactly. And I think that's a good analogy for these pancreatic beta cells and getting them back online, that this is absolutely possible. And I don't think that's mainstream yet. There are a lot more people talking about it, but I think it's also
it's not common.
so rarely.
It's not commonplace.
It's not commonplace because it's not commonplace for people to get the drastic help and assistance that they need early on to move the needle.
So in a space that does not have a lot of positive news associated with it, that's usually associated with a lot of doom and gloom, at least that's kind of what we see.
Yeah.
It seems to me like this is a rather hopeful message that would be useful to more people, certainly earlier in diagnosis.
I would hope so, for sure. And talked about insulin resistance and how that whole cascade of things can be rather like an avalanche, and things tend to go, like entropy is in full effect in the world of type 2 diabetes. Like it just tends to get worse and worse unless you do something to reel it back in. And I think a lot of that is understanding that there's a lot of hope in this, because I think oftentimes the plan, people go in to see their providers desperate for a plan, like, okay, coach, what do we do? Let's do it. And it's this blanket diet and exercise statement, or don't eat any white foods, or cut down on your carbs. And those generic pieces of advice clearly don't work. They work for some. And that's what I noticed when I worked at the diabetes center. Like some people would be scared straight, for lack of a better description. And they were determined, and they said, oh no, and did a complete 180 and changed everything. And these are the people that were successful with remission. And I think there's a certain personality type that can do that. But most people who already have stressors in life, whether it's a high stress job, children, taking care of elderly parents, financial insecurity, like food insecurity, there's so many different things, factors that could come into play, even just someone's ability to deal with stress. I often think of someone I used to know that I thought she had a cake life, but it's me being judgmental, and I apologize, but like, I was like, what care in the world is there? But everything to her was stressful. And so it's all just relative in how you deal with stress and how your resilience and your ability to take on challenge. But all that to say that I think people think it takes this complete, like if you're not that person that can do that 180, then all is lost for you. Then it's just going to be metformin, a SGLT2 like Jardiance or Farxiga or Januvia, any GLP-1 as well. By the way, Januvia is not an SGLT2. And so there's just so many, glipizide, your secretagogues. There's so many different medications in this space that are easily offered up. In general, not always, they're an affordable copay with your insurance. Sometimes they're not at all affordable, but in general they are. So it's like, okay, I just pay the copay, continue on with my life, and the drug's going to take care of it. I think that we're a bit conditioned in society to just take the medicine for that.
So I hear you say that the people that you've seen that have been successful are the folks that can do the 180.
Mm-hmm.
But I think we both know that's not normal. Forget
Right.
diabetes.
Yeah.
That's an
It's
unusual
not,
human that can,
they can flip the switch
yeah,
and do something different.
cold turkey anything, right?
Yeah.
We're creatures of habit, and
Yep.
in general, it's a lot easier to make small course corrections than it is to turn on a dime and start doing something that you're the opposite of what you're good at.
Exactly.
Right.
And that's why I say that was who was successful when I worked at the diabetes center in general. The people that I see that are successful now are those who do have those small incremental habit changes that stack on top of each other. And that depends and varies greatly to the individual. You have to look at what is the biggest thing what is your Achilles heel? What is the thing that is doing you in the most,
Okay.
whether it childhood trauma stuff that you eat your feelings away, or you just are in this rut of going through your day groundhog style and it's hard to be motivated to make a change, or it's a belief system that you don't believe it can be done, so you just continue to take the medicines and hope that they'll do the job for you. So it's any number of things. And then speaking of groundhog day and getting in the ruts, like as humans, we go through these processes, and think of it like these big tractor tire treads. The more you keep running that same program, the more likely you're going to continue to run that program. So you've got to switch that program that you're running on. And whether some people, that's just new information that's required to flip that switch, not really flip that switch, but to change the program. And for others, it's a belief that it can be done, or it's challenging the behaviors and beliefs that they had growing up around certain things. So
Okay.
just depends.
So again, this is information, not implementation, but I think there's an opportunity to make some pretty broad strokes, right? Let's say that somebody is newly diagnosed with prediabetes and somehow they end up scheduling an appointment with you. For most people, where do you start? Where's kind of, well, let's be very candid. There's not currently a medication available that by itself will result in diabetic remission in the absence of some degree of lifestyle change to accompany it.
Well, the definition of remission is an A1C below that threshold for diagnosis without medication. So let me just tackle
Okay.
that misconception while we're here. Is oftentimes I'll hear people say, I don't have diabetes because my A1C is below 6. And if your A1C is below 6 with medication, of course you still have diabetes. No, you cannot stop taking that medication in the absence of other behaviors that are going to make it so that when that medication goes away, you still maintain that A1C at that level. So that's something very important, because I hear that more than I believe I should.
I think actually that's a pretty common thing I see on social media. There's a lot of folks, rightfully so, very excited because they've gone from an 8 or a 9 down to a 5, 7 or something like that. And in general, I don't try and be doom and gloom. Let's celebrate wins where we can. But to your point, if they stop taking the medication, that number's probably going to go right back in the other direction. We talk about medication as a scaffold. In this case, I think it's probably more like a crutch. If you're getting around easily on the crutch, but you haven't done the rehab to enable that bum leg to be able to support your body weight, regardless of how easy it is or how well adjusted you are to the crutch, you're not going to be able to stand on your own two legs unless you do the work.
Yes. And I also want to emphasize again what you said about someone's A1C going from an 8 or a 9 to a sub 6, like that. That is phenomenal. And I would never, ever, ever take anyone's joy away for accomplishing that or say that's not a great thing because they have decreased their risk for diabetic eye disease. They've decreased their risk for amputations. They've decreased their risk for cardiovascular disease, for kidney failure. So that is not an insignificant thing. That is
and have taken a
huge.
tremendous load off that pancreas to enable
Yeah.
those beta cells to hopefully as many as possible to recover.
Yes, I think that where what you said really stands is if remission is the goal, then you do need to look at how can I safely come off of the scaffolding to keep the same A1C level, keep the good blood sugars without needing the assistance of the meds. However, if the assistance of the meds is needed, the assistance of the meds is needed. Full stop.
Okay.
I just want to be very clear on that.
So again, back to the original question.
Yeah.
So somebody that has been newly diagnosed with pre-diabetes, somehow they did something right and they end up talking to you very soon after diagnosis. And they've heard whispers that remission is a thing, probably called reversal of diabetes. That seems to be more common, but we're going to use the correct term and talk about remission.
Yeah.
Big broad strokes for most people. Where would they start?
Where would we start? It's not where, because if someone is asking me for help, it's no longer they, it's we. And we would start by looking at where they would like to be. What is the goal? What really makes them excited? What are they excited to do, to experience? How do they want to feel? Because I think oftentimes in initial sessions, people talk a lot about what they don't want to feel. I don't like the numbness and tingling in my hands and feet. I don't want to feel tired anymore. I want to look. Or I don't like how I look in a bait. Like it's all more on the negative. So we look and examine that and say, okay, well, how do you want to feel? How do you want to look? What would it mean for you if you could button those jeans or tuck your shirt into the front of your pants? What does that mean to you? Because what it means to this person doesn't mean the same to that person. Like, I don't care if I can tuck my shirt in or not, because I've never had that as an issue. But to someone, it could be a really big thing and even have meaning that's deeper than that superficial tuck my pants into the front. It could mean that I now look respectable. I look professional. I feel more confident about myself. And it's what's important to that person that we then map out a plan to get to that space. And it's a very realistic plan because I think oftentimes people get ideas about what that might look like. And they don't know if their ideas are realistic or not because there's nothing really out there to say so. They don't have that clear map and plan to say if you do A, B, C, and D, you could expect E to happen. What's a reasonable amount of weight loss where I know I'm not also losing muscle mass, that it's not just water weight loss? One thing I talk about often is people who've been low carbohydrate because that was what they thought was the way to go. And that could work for some people, of course. But if
I think for a lot of people, it can work really fast. And I think that's probably one of the appeals when you do go to that very low carbohydrate.
Right.
There tends to be a tremendous amount of weight loss.
And you know why that is?
Yeah.
We've talked about that. Because when you are restricting carbohydrates, you're not going to have as many stores in your muscle and in your liver. And if you don't have as many stores in your muscle, you lose a lot of water because it takes 2 molecules of water for every molecule of carbohydrate. So if you lose your carbohydrate stores, you're also shedding water and you might look more cut. You're going to weigh less on the scale. So there's a belief that, oh, look at this. This works. I've lost 3 pounds in a week when that weight loss is water weight. It's carbohydrate and water that they've lost. And look, the second carbohydrate crosses my lips. Look at all, I've gained this 4 pounds back. And it's just hydration and replenishing your muscles.
So you bring up a good point. I think the metric is, and correct me if I'm wrong, I think it's 5 to 10% of body weight loss is in general kind of the boilerplate recommendation for a lot of people that have this disease to have, let's just say, the lion's share of positive metabolic effect. How would somebody who is new to all of this, how do you differentiate between, I just cut a bunch of water weight? Let me rephrase. If the scale is the only tool that I have to measure success, how do I know that I'm doing it right? How do I know that I just didn't lose 10 pounds of water? Because I can do that in a hard enough workout. How does somebody just starting out, how do they vet that? How do they know that they're actually making meaningful progress and not just shedding water?
That's the question. Now, how do they know? And unless they are following some serious exercise physiologists, people putting out really good information on sort of what I just alluded to carbohydrate storage in the muscle and liver, they don't know. And beyond that, you don't know how much bone and muscle you're losing if you're in a chronic calorie restriction. So I use the word restriction over deficit on purpose because a caloric deficit can serve you well, and caloric restriction may or may not, depending on the degree of restriction. Because if you restrict too much, then you're in many ways telling your body to hold on to fat, hold on to things and not release it and let it go, so that that's why yo-yo dieting is a thing, because you go on a severe caloric restriction in order to keep your blood glucose levels at a certain rate, in order to keep your energy and to be able to use the energy you need to live off of. Your body can burn muscle for energy. Your body can start to use, in really dire cases, it can use your muscle, like your cardiac muscle, for people who are like more, I'm talking more like cachectic, anorexic type. And I don't think that enough people really understand that can happen. And like your blood is going to maintain a certain calcium level, end of story. And if it has to pull from your bones to get that calcium level, it will. So that's how you can get into the realm of osteopenia and osteoporosis. And that's something that is also quite common in could be quite common in teenage girls who have type 1 diabetes, that they don't take enough insulin so that they lose weight, and they can also, along with that, lose muscle mass and bone mass.
Without reading too much into it, it doesn't sound to me like this is something people are probably going to be able to figure out by themselves. that it would be very unlikely to just dig into the books and figure out how to do this without a lot of trial and error. Is that safe to say?
That's safe to say. And also, unless it's important to someone, for maybe they have a goal of being at a certain weight, or they just feel like they want to track that, that is something I really try to move people away from, is tracking their weight, because it can vary so much day to day based on hydration levels, based on the food that you've eaten, based on bowel movements, like so many things. So I would say if you feel like you absolutely have to measure your weight, then you get your weight, write it down once a week, same time of day, first thing in the morning, and you do it that Sunday morning, first day of the week. And then you just don't, like, if it's going to affect your mood, if it's going to change your behaviors, if you're going to say, if this weight is this, then I'm going to feel this way about it, I really don't want someone to weigh themselves in that case, because it's not helpful. And why would you do something that's not going to help you achieve your goals? Like, it just doesn't make sense.
So is it safe to say that while that 5 to 10% weight loss is probably the ultimate goal, it's probably more useful to treat even that weekly weight kind of similar to like an A1C. So something that's going to be a long leading indicator, but not going to be very
Right.
useful day to day and maybe even week to week. But
Exactly.
using the A1C example, if I'm comparing my weight on week 1 to say like week 12 or 13, that's probably more useful.
Yes.
Like in a
Because what
long-term trend.
people, right, because what people want is remission from type 2 diabetes. What people want is increased energy. They want to play with their grandchildren. They want to be strong. They want to feel good. They want to go on that vacation. They want to have an A1C that means they're at low risk for cardiovascular disease, diabetic eye disease, retinopathy, like all these things. So the weight is the metric for what they want. Like what they want is to look and feel great in a bikini and to feel and look strong. There are very few people that really and truly want to weigh 130 pounds. And let me be very clear with that, because I hear a lot of people like, I want to weigh 130. So it's not that, it's what weighing 130 pounds means to them. Like what in their mind that means. Does it mean that now people don't judge you based on your weight? Does it mean that you feel amazing when you're trying on clothes? Like the weight is not really what they're after. That you might believe that and think that's true, but it's really not. So a lot of what we do is diving into the real why behind what someone believes is their why, if that makes sense.
Okay. So I think this is probably a useful time to remind everyone that if they go to roadmap.thediabetespodcast.com, they can download our remission roadmap that has a lot of the kind of best practices, I think, to start getting folks on the
Mhm.
road to remission. For those that have listened so far, obviously probably can't take on the entirety of the population ourselves this week. What how does one start to is there a way to have that conversation outside of sitting down with a dietitian like yourself or something like that to start that reframe?
Possibly. And I often use this analogy with that. You could take off walking right now, and eventually you would make it to California. You would get there. I have no doubt you could get there. Will you be sunburned and have calluses all over your feet and blisters, and your time could have been used in a better way? Like that, it's a hard road to do that on your own. But
Mhm.
I have complete faith in you that you could get there. I don't know how long it would take, but you do it. Or you could get a bicycle and make it at some point, or you could get a plane flight, even quicker, private jet. So it's just a matter of, do you want to do it all by yourself the hard way, or do you want to lean on the expertise of someone who's been doing it for more than 2 decades and helped people do it? It's it's hard on your own to research enough to get someone else's experience through success with others and lots of coaching, and like it's just, I'm sure you could do it.
Okay.
I wouldn't chance it if it were me. I would not want my loved one, because the stakes are too great. If you don't succeed, that means there's a 30% chance that you'll need to take insulin in your lifetime, because about 30% of all people with type 2 diabetes need insulin to manage their blood sugar. And insulin's not the end of the world, but if you had a choice to not to, I would make the choice to not to. And like if I had a parasite let's say, like maybe eventually through copious amounts of diarrhea, like maybe it would eventually make its way out of my body. Probably not, because they have tons of babies and shed, and or I could take a medicine that can get rid of it in 24 to 48 hours, kill it. So I feel like of course, I'm not saying to take medicine, but I feel like that's my goal, is that we can work towards getting people into remission or do it the hard way.
Well, and I think you brought up another thing that maybe some people have some questions about. In your experience, what is a realistic timeline? So let's just be very candid. There is no switch. There is no magic bullet that you're going to wake up tomorrow and be free of diabetes. But for someone that wants to ultimately be off the medication, what's a reasonable timeline if they're going to plan, okay, today is day one of my journey. That seems to be a very common thing. I'm going to start the journey to California today. What is a reasonable amount of time to get there for, let's just say, for a lot of people? Because it's varying, and I know this is, but in your experience, what could somebody shoot for and have a reasonable chance of achieving? And I know it depends, but
I know you're saying that because I'm making a face at you. And a reasonable timeline depends on what you do. Like there's so many variables. A reasonable timeline depends on if you are flying a private jet or if you're walking. So that timeline is going to vary wildly. And if you're walking, you might get delayed by rain and snow and sleet and shelter issues.
Fair enough.
Yeah.
In the people that you've worked with, that you've coached to get to remission successfully, what is that timeline generally?
So it depends on if they're on meds or not, if they're on insulin or not. And the timeline to see results is usually 2 weeks.
Okay.
And then
so when you say see results, what does that look like?
Yeah, sometimes it's coming off of an oral medication already because the blood sugar is good enough
within 2 weeks.
Do so. Yes.
Okay.
Someone else I've worked with within 4 weeks was off of one of her insulins. So it really depends. That depends on how much changes, how many switches get turned. But in general, 3 weeks is enough time to measure progress in more black and white type ways. You see a lot of gray progress in terms of like subjective stuff within a week or two. But like some of these same things you could get with the placebo effect, So I don't necessarily say 2 weeks, but after 3 months, you absolutely have enough data to show month over month over month improvements. And then you also will have an A1C, but it depends on when they go back to see their doctor, like where they do for an A1C 1 month after you started or 3 months after you started. Are they wearing a continuous glucose monitor to really see that? Or what are we measuring success by? And a lot of that depends on what the person wants to see, what they want to achieve as well, with the overall goal always being type 2 diabetes remission. But it's fine to focus on one aspect of something and go that way first, because that's what lights people on fire. That's what motivates people. And that's what it is. It's just being motivated and seeing what's possible. And a lot of that is just banking small wins. Like you have this small win and you keep going, just creating momentum from each of those small wins until at the end you have this big treasure trove of wins.
So something that you said that kind of resonated with me is diabetes is going to change your life, right? Like there's and a lot of people that we talk with, there's a resistance to, when we talk about some of the things that we do, very often there's that sounds hard, or that sounds challenging. When really what we're saying is these are changes that you can choose, right? But changes will occur. whether you intentionally choose or not. Your medication will most likely go up if you don't do anything besides just taking the medication.
It is a
In,
progressive
general,
disease.
we do not see the volume or quantity types of medication going down over time. In general, that tends to go up, oftentimes with the side effects of those. So if you can just in general accept that diabetes brings change and that you get to choose which changes to make with this disease, some of those choices will make this easier and some of those will ultimately make it more difficult in the long run.
Yeah.
It's there's a lot of choices, but the upside is that you have the power to choose which ones you want to make.
Well, when you say choices, I think that oftentimes people don't believe they're in choice. There's an overwhelming or maybe too abundant belief that I didn't choose this. And no, you didn't choose to have type 2 diabetes. That's not what I'm saying. What I am saying is that any day, in any moment, you choose how you show up. You choose your mood. You choose what you're going to do to a point, of course, because sometimes a belief that I may tell myself is I choose to show up in joy. And then I get somewhere and it's a bunch of grumps all around. It doesn't, and then it's like, I was in joy until, but then you're giving your power away to other people. So you have to say, I choose to be this way, completely unaffected, not necessarily unaffected, but unwilling to change my choices based on the circumstances around me. And I believe that the food environment around people can really affect how someone decides to show up. And what I mean by that is you wake up in the morning and you're like, okay, today is day one of eating healthy or day one of my diet. And then lo and behold, it's Casey's birthday at work and there's cake and you forgot to pack or you thought you had packed enough snacks to have at work. So you haven't eaten in 4 or 5 hours. You're starving. The hunger monster has come out to play. Maybe there was more stress at work. So you've got ghrelin and leptin at work, those hunger hormones in your brain really overriding everything. And then here's this high sugar, high fat thing in front of your face. So then the you that made that decision that morning, are they still going to show up in that moment with the cake? And it absolutely depends on any number of things. And most of the time, the cake is going to win. And that is just biology. It's not because you have horrible willpower. It is because you are designed to eat ever so often, to enjoy high sugar, high fat things, which are overly abundant in today's environment. So the best thing you can do is prepare ahead of time for unforeseen things. And so when I work with someone, we talk about small wins. Part of what we do is over prepare for things. And I think I have a friend named Jen who does this better than anyone I know. My friend Jen is vegan, so she will not have any butter or eggs or not vegetarian, none of that, like will not have it. And the best way to know that she won't be starved and I wouldn't say she would be tempted by any of this because that's just, she has very strong reasons for why she does this. But she packs her own food. She plans, she prepares. And some people listening might say, who has time for that? And it's all about where your priorities are. If your priorities are in alignment, you make time.
Well, so I would say the difference is that it's not so much that she's making better choices. It's really when she's making those better choices, right?
She's making them from a
is-
state of power. She's making them when she's at home. She's thinking about them 3 and 4 days before she's there. And this wasn't an overnight thing for her. This has been practiced and honed. And I've had conversations with her, and I've seen different things that she's done where it's like, was first vegetarian but still lacto-ovo, and then she saw some inhumane practices at a dairy farm that really strongly motivated her to cut that out, because she's a lover of people and animals, just a beautiful soul. I love her dearly. And for her, it was just not something she was willing to compromise on. And so just behavior change after behavior change to get to that point.
Okay. So I
have many friends named Jen. So I think if your name is Jen, we're friends.
You do have a lot of
I have a lot of Jens.
Yeah.
The Jen that I'm talking about knows this is her. But I also have another amazing Jen and another amazing Jen. So it's like
so many quality Jens. Yeah.
Quality. High quality.
All right. So I think normally we try and give people something that they can take away. Again, strongly encourage you, go to that roadmap.thediabetespodcast.com, get the plan to start working towards diabetes remission. But I think the takeaway for today is just that start to really drill down on everything is choice. And you have the power, regardless of where you are on that diabetes journey, to make choices that will make it better or make it worse.
Yes. And so to give an actionable thing around that, if you feel yourself in a point or state where you are not in choice, you can just simply ask that question. How can I be in choice? What can I choose? How can I claim some semblance of power back in this moment? That's a good thing to ask to start. Another thing is, how do I want to feel? If you find that you're feeling down about yourself, or you're feeling uncomfortable, or you're feeling just some kind of way, try your best to do a pattern interrupt and ask. Like, first, awareness is the first big piece of that. And then the second is, how do I want to feel right now? And then do your best to just do it. Just feel. Then how can I feel this emotion? How can I feel this way? What do I need to do? What do I need to change? Who do I need to become to feel that? So that's a little small smackerel into what I tend to work on with clients who want to put their diabetes into remission. Very small.
Because again, it cannot hammer this home enough. The exact path to establish the exact behaviors that are going to work for you for the rest of your life varies wildly. There are a million different ways to do this. All of them require change, and you are officially empowered to start making those changes.
Did you do like the
with the expectation that it not only can get better, but almost certainly will get better, whether that's complete full remission, no meds, or it's just like we talked about earlier, those numbers are more in line with less damage to my eyes and feet and all the other kind of stuff. Regardless of what level of success you can ultimately achieve, any move in the right direction is success. Any move in the right direction is welcome and will make sure that the rest of your life is as pain-free, is as mobile, all of the other things that go along with increased quality of life. Those are within your grasp, and you can start making those choices today.
Absolutely.
All right. Well, this has been yet another episode of the Diabetes Podcast. Thanks for listening to the Diabetes Podcast. If you like what you heard, please click that follow or subscribe button. And don't forget to check out roadmap.thediabetespodcast.com for that free diabetes and type 2 diabetes remission roadmap. Till next time, take courage. You can do this, and we can help you.